So I would be seeing this patient in the office month after month, and then they would get hospitalized. And then after that hospitalization, it was different. Oh, yeah, now I know what you do in the mornings. You are the first person to show up at my bedside in the morning. You examined me in that bed. There was a familiar face. Of those 30 people that came by my bedside, I knew you. And you had a part of my care. You were in control of my care. And so that relationship changed. They knew now another part of me.
Welcome to Flourishing in Medicine, from Surviving to Thriving. I'm Mick Krasner, and this podcast is produced by MPro, a medical professional liability insurance carrier headquartered in New York, committed through a number of peer support offerings to supporting the physicians that we protect. And today I'm joined by Dr. Donald E. Moore, a Yale-trained physician, longtime Brooklyn primary care doctor and hospital attending, educator at Weill Cornell, Downstate and Pace, and a leader in the Medical Society of the State of New York, where he has chaired the Committee on Physician Health and the Wellness and Resilience Committees. In this conversation, Dr. Moore traces his calling in medicine from a formative college biology class to a humanistic medical education at Yale University. He reflects on ethics, trust, and beneficence in everyday care, and shares what 2 decades of making over 20,000 house calls taught him about relationships and real continuity. We also explore professional well-being and real collegiality, and why physicians should lean into curiosity and responsible AI. It's a candid story, rich with its view on how to practice and live medicine with integrity and joy. So this is a real pleasure to welcome you, Donald, to Flourishing in Medicine, from Surviving to Thriving. I'm looking so forward to this conversation.
Nick, it's great to be with you again, as always. I always enjoy my time with you. Love to talk with you.
So I'd like to start with a question which I ask most of our guests, and it's about kind of your why in medicine. And so, we have a lot of choices in our lives growing up. Maybe we don't realize at the time that we have choices, but we really do. And you made a choice to pursue medicine. Now, I'd like you to think about this beyond biography, beyond, the instrumental things that happened to you, but among all the things you could have done with your life, with your talents, which I appreciate so much, with your intellect, with your skills and commitment, why medicine? What was undergirding that? What were the formative things in your life that really had that make the most sense for you at the time and continue to make sense for you?
So for me, that's an easy question to answer. I was called to medicine. When I started college, I had no idea exactly what I was going to do. Maybe I was going to study law. And then I took a course. It was called Biology for Non-Science Majors. So I was not thinking about medicine. And, the teacher was so good. When she laid out the biologic processes, I just really was captivated. Every test that I took, I got 100. I never got 100 on a test before, and this was happening all the time. So at the end of the course, she says, "Why don't you become a doctor?" And it's like no one had ever asked me before. As a matter of fact, no one had suggested what I should do. And I just said yes, because, just to be asked, that was such an honor. That was such a lead. I just took the lead and I said yes. I had no idea what I was getting into.
That's fascinating, and that's really interesting. You didn't know this about yourself, so you really learned something about yourself. It really lit your fire, just the biology, something about it. And also being asked by someone you respected a lot, this teacher who you felt was responsible for really turning you on in a certain way intellectually. I'd like you to dig just a little bit deeper even into that same question. Why were you so excited by this? What was it about what was happening to you as you began to learn biology? And also, what was it about the possibility of being a doctor. What did that mean to you, and why would that be important?
Well, let's start off with my mother was a nurse. So, but I just knew she wore a white dress, she wore a white cap, and she would go to work every day. She had multiple jobs. That's all I knew about nursing. She had these books that said how to lay the tray for an operation, and I would look at those books. I'd be fascinated by it, but I did not put myself in the context of being a doctor. What I did like, though, was the science. I did like that biology course. I did like the biologic processes. I did like learning that. So I thought that, okay, since I like the material, I'll just become a doctor and do that. And I can only remember as a child, up to the, as a child, growing up to young adulthood, I only went to a doctor once, only once. And I believe the reason I went to that doctor was because it was necessary for school. And it was one of the most horrible experiences I ever had. This was in the Bronx. It was in a house, a private house. The Bronx has these private houses. And it had a yard. And the doctor's office was in the house. So when you got to the yard, there were people all the way out to the gate, all the way out. So it took a few hours to get inside the house. And when you got inside the house, I mean, this was a horrible experience. People were lined up going up there was a staircase. There were 2 stories in that. And the staircase was inside. So, and there were people lined up. And I think the office was up on the second floor. And I thought, well, I fortunately, by the time I got to college and I was called, I had forgotten about that experience. I remember that in retrospect. So I had no concept of what doctoring was when I did it. And that's why I believe I was called, because it was not something I chose. It really was something that chose me. And I had to learn after that point how to be a doctor.
As you reflect back on suddenly being excited by the possibility you could become a doctor and this teacher that you respect suggesting that you love biology, and then having had that one singular experience of like horrible, I would never do that, or maybe that didn't even cross your mind. Do you see any connection between that? I'm drawing connections and I don't want to falsely connect those, but between the nascent activism in medicine that has been a hallmark of your career and that dichotomy there.
Well, what was very fortunate for me is that the medical school that I went to, I don't think I could have gotten a better medical education. Uh, Yale has a system of medical education that I think is somewhat unique in this country and probably unique worldwide. It's the humanistic system of education. Now I'm studying AI. I'm working on things like feedback, how you get feedback as you go. Well, the feedback we got as Yale medical student was quite different. We didn't get examinations. So we didn't study for a few weeks and then get an exam and you get your reinforcement that you have learned the material and you get, an A or a 90% or whatever. The feedback we got was none. So so basically, we were expected to figure out how to study. The resources are here. Everything was fabulous. It was fancy. The environment was, some people refer to it as a country club, but everything was there. And you got guidance. They didn't just throw you in there, and you were taught. There were lectures, there were material, everything was there, but nobody said, okay, you study this today and we'll test you tomorrow. So everything had to come from within you. And that was me. That was the type of person that I was. I basically, when they said do medicine, I didn't have to figure out when the teacher suggested do medicine, I didn't have to figure out, okay, can I do this, whatever, whatever, whatever. No, I knew if other people could do medicine, then I could study medicine. Yeah, and I could tell you part of the preparation to be a doctor for me in high school, I went to high school in Jamaica, and we wore khakis, khaki pants, khaki shirt. And we didn't have a lot of resources, so you had maybe one or two sets of uniform. So, and you would rotate them. So let's say something happened to, your shirt got messed up, whatever. You had one option. You could wear a white shirt. And I would just love to mess up my clothes so I could get my white shirt because I love to wear the white shirt. And I would go to school, as a boy. Boys go to school, they rumble and tumble. I would go to school in my white shirt. And in the evening, I'd be coming home and my white shirt was the same way it was when I left the house in the morning. I would never. So there were sort of just things that were me that I liked. I was very particular about cleanliness, and I felt that hospitals and doctors should be clean. So, there were just certain characteristics within me that told me that this is the kind of profession I wanted to be. I didn't want to get my hands dirty, that type of thing. Even though in medicine you do, you should.
You're describing not just the kind of profession you wanted to be in, but the kind of professional you wanted to be within that profession.
And the type of person that I wanted to be. And, I'll just throw this in there. For me, medicine, it's not a job, it's not just a profession, it's a life. Now that I don't see patients clinically, I feel as much a doctor today as I did when I was seeing a patient a year and a half ago.
Your mission, as you've described it in some of the things you've written, you advocate for a healthcare system focused on patient care, access to quality medicine, ethical doctor-patient relationship rooted in trust and beneficence. So I just want to highlight a couple things. Ethics, trust, beneficence, those three words, ethics, trust, beneficence. Can you just talk a little bit about how that translates operationally into reality? What are the rewards and benefits you get by holding that as part of your mission? I'm asking because a life in medicine and a career in medicine, it's not 100% altruism, although it is and it isn't, because we are, as human beings, as social species, we are evolutionarily designed to care for each other. And that design includes tremendous rewards, physiologic rewards to care for each other. We get oxytocin hits, for example. We get all this reinforcement that says, yeah, I will actually even risk my life. I'll go in during the pandemic when we didn't know what kind of pathogen this was and care for others because there's this thing that keeps our species alive to do so. So I'm interested in those parts of it. How is that operationalized? Ethics, trust, and beneficence. What's the practical part of that?
As I mentioned, I felt that I was taught to be a good doctor at Yale Medical School. So I knew, at least when I left, when I graduated, what a good doctor should be. I didn't know myself all the things I had to do, nor did I have the knowledge to do that. But I knew that I had to acquire that knowledge, and I knew how people could be treated. But that's not the world that I entered into. As a resident, things changed. We went from a humanistic form of education to one of constant testing. And, in residency, it wasn't the written test, it's the test every day. You're being measured, you're being shaped. And I was not an easy person to shape. As a matter of fact, I resisted and resisted. So the conflict started very early, with me and the system, the administration. I'll tell you a story. When I was applying to medical school, they had a peer evaluate you. And the peer was actually my good friend. He and I were in student government together. And, they said, well, tell us, we know that this is going to be a good student, whatever, because grades, everything, and testing. However, tell us what kind of trouble or what are the things that are going to be obstacles for this individual. And he nailed it. He says he's going to come up against the system, the administration. And it started as soon as I got into residency. And things didn't go well. Then I started working. Things didn't go well because remember I told you that for me the concept of medicine it had to be a clean place. I started working in a public hospital, and I learned one sort of medicine here in New Haven, and I'm in Brooklyn, and they're delivering something different. I'm going into an examination room, and it's dirty. So what would I do? I would clean the exam room after I call them 4 times to clean it. And I would stop. I said, well, I'm not going to work here like this. And I would, figure out where the mop was, and I would start mopping the floor. And it would make the people so upset. The next morning, I would get called up. Patients were waiting while you were fooling around. But so I don't think so. So there were these conflicts. But to me, I'll tell you another story. So I had a student more recently, and the student came from the Ivy League school to precept. I was this preceptor in my office. And I know that the school taught their students how to dress. They told them, you're going, because they taught me to respect patients and respect my environment. So and I was part of the training of those students. So I know, and I had many students before this particular student. So the first day the student showed up, he was casual for a medical student. So, I didn't say anything. A couple of times, he remained casual. So I remember one morning I would meet him, I would take him to the doctor's lounge. And I felt embarrassed one morning because the president of the hospital came by, and here it was. I was with a medical student. He had no name tag, he had no white coat, he was in a casual shirt, and I'm introducing, this is my student. So I am taking responsibility now for his deportment because I am his preceptor. So he asked me at some later point for feedback. And I mentioned that. Not only did I mention that, I mentioned his management, his patient care management. I mentioned that he was giving me examinations that he probably didn't do well because he had not done certain things like followed my lead in disrobing the patients and so on. So I said, well, how could you have known this without, doing this part of the exam? Well, he reported me to the administration for harassment and things like that. So now this student was clearly wrong. And the administration, I don't think, dealt with it correctly because they were more concerned about, I'm not sure what they were exactly concerned. My thought is they were more concerned about not offending the student, and the student made some other lies, which I think that a medical student should never lie. A doctor should never lie. And he clearly lied but he was concerned. He was concerned that he thought I would have penalized him for the grade, which I wouldn't. I had no intention of doing it. I was just trying to teach this student. So as I continued to practice, I just saw the hypocrisy in medicine. I saw how poorly patients were treated. I saw the disrespect for patients. And I go back to my early experience. That was the only experience I had. And I knew that this is not the doctor that I would ever be once I saw what good doctoring was. So the beneficence, you've got to be thinking about good all the time. And, I don't know, you probably know that at some point I dropped the commercial insurances because I went head to head with them. When they started telling me that I needed to see patients, and they didn't say it explicitly, but if you're going to pay me for a 10-minute visit, I can't survive. And when I didn't do the 10-minute visit and I billed them for the 30-minute visit, they said, well, you can't do that. And I said, well, this is what I did. And they said, well, you can't do that. And they took the money back. And, and said, well, you're not behaving right. And I said, well, this is how I'm going to behave. And when I spoke to the attorney that represented me against the insurance company, he says, well, you still have your patients. But I said, well, how can I see them if the insurance company is not going to pay me? And eventually I just dropped the insurance companies, and I had a better life, and I was able to continue the care of my patients in a different way. Of course, when you have these struggles, you're going to lose something. Like I didn't have access to many of my patients with insurance, particularly the ones who couldn't pay directly. And, I limited it to, Medicare and so on. So I know your question was sort of more specific, but I'm generalizing it to show you that this is how I got there. I did, plus I read about these things. I always, again, being an autodidact and being someone who was taught very early. If you want to know how to become a good doctor, you can read about it because there were many good doctors before me. Many, many.
You learn the value of taking responsibility for your own education in a very important way, and that's something all of us, I think, in medicine should be doing because there's so much to learn and so much to experience, and it's not a cookbook ever. So I think you answered, and these stories you told about the ethics, trust, beneficence, I think you used really good examples. And what you just said, that you take care of your patients in a different way, I'd like you to connect that with something that was a big part of your experience, which was making home visits, because I think that's an illustration of your calling, but also, how to really care, that you always kept the patients at the center. And why do I want to talk about this on a podcast that has to do with flourishing, our professional flourishing, because it did very much help you flourish. It was the best way you knew how to flourish. So, yeah, please share with us about this taking care of patients in a different way. Many of us have done home visits, but to the extent that you've done home visits, not even close. So, I want to hear a little bit about that.
Okay, so I probably did about 20,000 house calls, Manhattan, Brooklyn, and elsewhere. I even Long Island. I remember I used to travel out to Long Island, an hour and a half at rush hour to see this student at Hofstra. So William Carlos Williams, he made house calls. He made house calls in New Jersey. And when you read those stories, it gives you the knowledge. If you never had those experiences, it gives you the experience and the knowledge what it is like to be a good doctor. Well, why did I make house calls? Well, I started making house calls first of all because it was a job. Things didn't go that well in the residency if you're fighting people, and things don't go that well early in practice if you're fighting again. So you take jobs. You take jobs that you're offered. So I actually joined a group. That's what they did. They made house calls. But I liked making house calls. It just seemed like the natural thing to do. And I heard that people like William Carlos Williams did house calls. But there was a more concrete mentor. There was a doctor in Brooklyn. His name was Gerald Dees. His name is Gerald Dees. And whenever you mention the word house calls, people would say, "Oh, Dr. D's make house calls." And they always said it and they lit up as if to say, "Well, Dr. D's make house calls." Well, my goal was to make more house calls than Dr. D's. And I did. So I met Dr. Dees. I was impressed with Dr. Dees. He was a mentor to me, and he did a lot of the things that I'm doing today. He would write. He would write about the proper way for the doctor to behave. He would write about the proper way for the patient to behave. This is not a one-way relationship. Patients have a responsibility. Doctors have a responsibility. So the house call thing, it was only natural. I refer to the way I eventually managed my practice was horizontally. I saw the patient in of their experiences. I saw the patients in the office. Then, when I used to only see patients in the office at one time. And then I would remember this experience over and over. A patient would come in after I hadn't seen him for a while and would say, "Oh, I was in the hospital." And I would say, "Oh, really? What happened?" "Oh, I had this and this, and I was at this hospital and da 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 da." And one of the things that they said but didn't say explicitly that I heard was, "And you weren't there." So when I got the opportunity to get hospital privileges, I took it. So then when my patients started getting hospitalized, when they needed hospitalization, I would say, "Go to this hospital. This is where I am." And they invariably did that. And you know what happened after the hospital experience with almost every patient that was hospitalized? It changed the relationship after that. So I would be seeing this patient in the office month after month, whatever, and then they would get hospitalized. And then after that hospitalization, it was different. Oh, yeah, now I know what you do in the mornings. You are the first person to show up at my bedside in the morning. You examined me in that bed. There was a familiar face of those 30 people that came by my bedside. I knew you, and you had a part of my care. You were in control of my care. And so that relationship changed. They knew now another part of me. So that relationship, doctor patient, it's both ways. And once you begin to see the patient in different ways, if you go to a private affair for a patient and you show up in their lives in a different way, it changes the relationship. Once you've been to their house, oh, wow, it's quite different, right? Francis Peabody, the secret of the care of the patient is caring for the patient. When you go to somebody's house, it changes that relationship. You know something about them that most of their other doctors will never know. Most other people will never know. And it's like examining somebody. When you examine a patient, whether or not you get something from that particular examination, and you always get something from that particular examination, because the process of doing that examination is a bonding. And after you've done that, okay, I can trust you now because you know me. If you give me the medicine, I'm going to take it because you have examined me. And you have examined me in multiple ways. You've spent time talking to me. That doesn't occur in 10 minutes. That's hello, right? How is a family? So when you put the exam, the interview, an interview, nobody can do what you do. You're interviewing me. You can't send a surrogate. They wouldn't get this out of me. You're getting it out of me because you're an interviewer, you're an examiner. There's skills that a doctor has to learn, and it takes a lifetime to learn those skills. The book that I read on interviewing the patient was this thick, you know, 500 pages of how to ask the patient questions. So if somebody's going to spend that much time and effort writing about it, it must be something really important. Physical diagnosis, very important. So that horizontal, you've got to see the patient in all aspects of your life. And that means, I hate to say this because this is the world today, how can one fulfill all aspects of being a doctor if you're a hospitalist? I will just see you in the hospital. And after my shift is done, I'm gone. And by the way, I won't be here for the next 3 days because I have those of my days off. And the next hospitalist will fill in. So, yes, you will live, but will you be cared for?
I think you're right. I think we've given up a huge amount, and a lot of it we haven't even realized what we've given up. And listening to you is very motivating and inspiring. And I'm hoping our listeners, will at least question themselves and say, how is it that I can best care for the patient, as in Francis Peabody's words. One of the things, as you were describing the physical exam, I'm thinking of Dr. Abraham Verghese, who talks about touch and the physical exam. You cannot bypass that because not only is it this bonding that you describe, but it's a ritual. And a ritual is about transformation. And if you bypass that ritual, and you described your medical student maybe didn't disrobe the patient and do the complete exam, you're really bypassing the opportunity to help the transformation of that patient move through an illness, move through whatever life experience they are in at that moment. So I think that's really, you make a great argument. Given this and all this commitment and getting a lot out of it yourself and realizing this is the only way that I, Donald Moore, can actually practice and live in medicine and feel good about myself, you have committed a lot of your time to the well-being of your professional colleagues. You at one time were chair of the Wellness and Resilience Committee at the Medical Society. And I'd like to just shift because of the focus of this podcast about, what led to that? What was it about wellness that was really important to you? What were you seeing in your colleagues as maybe their lives and their practices became fragmented the way you just described, with hospitalists, this and that, and insurance companies and so on? And any examples or stories, because you're a great storyteller, of initiatives, policies, experiences that kind of illustrate how each of us, in some level, can take leadership and be impactful?
Well, I think the tone, the subject of our conversation is thriving in medicine. And I think to thrive in medicine, you've got to participate in a lot of different aspects. And I think a big part of thriving in medicine is interaction with your peers. Now, the medical society is where we interact with each other. We have interactions with patients. But part of being a doctor is collegiality, the being with your colleagues, and if together we're stronger, and that's what a medical society does. So very early in my interaction with the medical society, I was appointed to a committee on physicians' health. And one of the nice things when you interact in those organizations, you meet different types of doctors. You meet doctors at different ages. So you meet doctors much further along the line than you are, and you meet younger doctors, and you meet doctors like yourself. You also meet doctors in many different specialties. Well, I eventually became chair of CPH, Committee on Physicians' Health, and that's the organization, that's the part of the medical society that takes care of physicians who are impaired substance use, psychiatric disorders. So while we were managing those impaired physicians, one colleague said one day, we're downstream here trying to fix the doctors as they are impaired and they're about to lose their license. Why don't we go upstream and do an earlier intervention? And that's where the whole concept. So the medical society formed a task force on burnout because that was when burnout was at its peak. The electronic records were beating us up, and we were struggling with it, new technology, and so on. And I love all parts of medicine. I love the technology. You probably know that I was very early adopter of the electronic health records, and I'm still chair of the HIT committee, and I'm still involved with artificial. I'm now involved with artificial intelligence, and so we formed a wellness committee. And when I moved off of the CPH as chair, I am now currently the chair of the wellness committee. Again, as doctors, we do different things. We do prevention, we do early treatment, and then we do treatment at the end. And let me throw that one in there, treatment at the end. When I took care of my hospitalized patients, and unfortunately in medicine, all our patients are not going to survive, it would not upset me, but my colleagues never understood why, when it got to the point where a patient was now hopeless, that I wanted to hang around and I did not do what I was requested to do. Okay, it's time to hand off to palliative care. No, I did get palliative care consults, but I got them for the difficult cases where there was no solution and I needed help. I did not want to abandon my patient. I took care of you for 30 years and now you're dying and you won't see me because I am no longer here. I'm handing you off. I never had that problem with the house calls. Well, to some extent, yes, because there was home hospice. And when we got to the home hospice, your relevance sort of diminished. But I still would try to maintain that relationship because when a patient gets to that point, you're not just treating the patient, you're treating the family. There are people that are affected by what that outcome is likely to be. So that was my involvement with wellness. It's part of the whole horizontal care. So if it's the horizontal care of the patient, it's the horizontal life of the doctor. Young doctor, middle-aged doctor, older doctor. Before you get to your next question, I just want to show you what good doctoring is. I used to be so fascinated when I would go to these pharmaceutical meetings on a Sunday morning at 7:30 in the morning. And these 85, 90-year-old doctors would show up. And they could sometimes they have their walker. And I used to think, what is this 90-year-old doctor showing up for a medical conference? What he couldn't, I mean, maybe it's breakfast, he's here for whatever. But no, these doctors were showing up for two reasons. One, collegiality. They wanted to be with other doctors, but more importantly, they really were interested in learning medicine at that age. And I hope that that never leaves me.
You know, you talked about some of the variety of things that you're interested in. That's one of the things that I find so attractive about being in your orbit is you're endlessly curious. You, are interested, especially in things that are applicable, salient, relevant, impactful, especially to our professional lives. And we won't get into our ages, but I would say that you have a very youthful outlook that everything is new. What you just said, that you want to continue learning just like these older doctors that would be at these educational activities. So one of the areas that you just talked about that you're really interested in is artificial intelligence and how to understand it and how to apply it professionally. So just talk with us a little bit about that, because I think our viewers will then hopefully, investigate who is Donald Moore, and they'll find you've already offered some discussion on that is available to the public, to our colleagues. So
I think it was Osler when he was giving a lecture to the medical students. He said, I'm sorry for you guys because I have lived a medicine on the frontiers. When I started practicing medicine, we didn't have this, and all of these things occurred during my lifetime. Well, guess what? This was 100+ years ago. When I started medicine, HIV did not exist as a disease that we treated. Just out of residency, no, just when I started residency, HIV came about. I was curious. I wanted to know what this disease was. I became an HIV treater. All my patients died, in the beginning, and then all of them lived. So I started my career with a pandemic. And then, as I'm getting closer and I'm saying, oh, I think I'm going to be shutting this down in a little while, boom, we're hit with another pandemic, the COVID-19. Now, I was a student of the 1918 pandemic. It fascinated me. The pandemic, the Black Death of the 14th century, fascinated me. So imagine having the opportunity of a doctor to be involved in sort of saving mankind. Of course, that's in my head. We don't, mankind evolves or whatever. So the curiosity and the desire to participate. As a matter of fact, remember when Ebola came and they said, oh, this disease kills almost 50% of the people. And I remember watching the doctors put on their PPE, so they could go in to this dangerous situation. And I thought to myself, could I do that? Could I not make a mistake? Could I? Because if I make a mistake, I'm going to die. So when COVID came and we finally got our PPEs, I wanted to learn how to put this thing on. It seems so simple. You're just going to, no, it's not simple. There is, even the simplest, medicine is not simple. Medicine is an art, it's a science, it's something you have to dedicate yourself to learn. Well, okay, 2 years ago, all of a sudden, our medicine is just about to explode, transform into something different. So why wouldn't I want to be part of that? You know, okay, the computer scientists, they've been doing this now for 50, 60 years. They've been working at it, but it was never good enough for prime time. Now it's good enough for prime time, and they're telling us this is where we want to apply it. This is where we can really do good. So it's up to us to meet them halfway and said, I know the medicine, you know the computer science, but we've both got to learn a little bit of each other's stuff so that we can make this work. And so I spent the last 6 months, 9 months, a year or so, just taking a deep dive in learning. I won't be a computer scientist, but I hope that I'll be a doctor that has a lot of knowledge about artificial intelligence in medicine. Of course, if I learn artificial intelligence in medicine, I'm going to know about artificial intelligence in my living room when I turn on my large language model and start querying. I'm going to learn how to write better papers. I just wrote an obituary, just tidied it up with Chat GPT. That's an art. But now I can become an expert. So this gives us the opportunity to become experts in areas where we don't have to put in all that long studying, but we already know how to study. We've done it. So this stuff should be right up our alley. And I'm just hoping that the doctors, and they are, I'm very proud of us. We are embracing it, because if you look at the polls in 2023, only about 30% of the doctors said, I'm really using this stuff. Maybe I'm using it. I don't even know. And, a year later, it doubled. So this is one of the fastest transformation, but it's not just doctors where this transformation is occurring. It's occurring in the entire society. And as doctors, as the scholars, we're scholars too. As part of that, as part of the intelligentsia of the society, it behooves us to make sure that any technology, any science that occurs, doctors are a part of it.
Related to this discussion is curiosity. I mentioned that earlier, and your curiosity. And I want to just say a couple things about a program we have coming up. Our listeners and viewers should be aware that on November 4th in New York City at the New York Academy of Medicine, we're going to have a program on curiosity, a free program with 3 hours of CME. It's election day in New York City, so you can go vote and then take the day off and have the afternoon with us at 1 o'clock up on the Upper East Side there. Donald Moore, myself, and Lisa Sanders, Dr. Lisa Sanders, also a Yale graduate and columnist of the New York Times. She has a column called Diagnosis Unsolved Cases, you see in the New York Times Magazine. We'll be having a discussion on curiosity. Donald may speak a little bit about this dynamic of curiosity. Maybe he'll talk about AI. I don't know exactly, but he's a great storyteller, so he'll tell stories. I'll tell some stories. Lisa, who has a book called Every Patient Tells a Story, will tell some stories. Donald, I find the reason why I wanted to create this educational activity is I find curiosity so central to what it means to practice medicine. It's a faculty, we can call it. It's an important faculty in our professional lives, and might I say, probably our personal lives. The time that we lose our curiosity for our relationships, for our environment, is the time that we are no longer engaged, and that our environment suffers, our relationships can suffer. It helps us stay on track. It enriches this sense of wonder, this sense of awe, and also this sense of meaning. And I'd like creators to talk, maybe just riff a little bit on curiosity, just as a faculty, as a capacity, as an important quality that you have personally, but also make an argument to us about why it's so central to our life in medicine, not only to do our work well, but also to flourish ourselves.
Yeah. Well, curiosity is integral to medicine, to science, all of science, but medicine in particular, because we know, even today, I can say we know so little about our own body. We know so little even about the drugs that we're using. Well, we're going to get help, right? Because now we're creating machines that can get very smart. However, what we learn from those machines is that, yes, you can supervise the machine and teach it something, or you can let the machine use its own initiative to learn from the data that you give it. So there is unsupervised learning. But then they got stuck. Things weren't progressing. It wasn't until they got to reinforcement learning that they said, okay, now this is what deep learning is. It's that reinforcement. The computer now is moving along, moving along. But even with reinforcement learning, they learned, these are the computer scientists, they learned that eventually learning will stop unless there is one additional aspect that you put in that algorithm. And what they put there is curiosity.
Wow.
So, in the gaming industry, they learned that because the machines, the games, they would play the games and with their algorithms. And if the game got very complicated, for example, I think there was a particular game where this person is supposed to go through a whole series of steps. They created incentives and reward for that person to go over a certain amount of steps. But at some point, the computer would stop, the machine would stop and not go any further because the machine was lacking curiosity. They programmed curiosity into it, and the machine went further. The problem that we will face, though, is how curious will that machine become? Will that machine become so curious that it wants to create weapons to destroy us and take us over? And that's what people are worried about. Yes, we should be worried about that, but we're not there yet. But it shows you the importance of curiosity in learning in general. And if we want to solve the problems in medicine, we can't take curiosity away from medicine. Most of the great discoveries in medicine were not based on rewards that people were given for each incremental step. It was the scientists, there's Nobel laureates. Most of them eventually ended up, the ones who get the Nobel laureates are the curious ones, the ones who go beyond and start looking in areas that others weren't looking. They didn't follow that path. So this cookie cutter creation of doctors, yes, it's going to go on for a while. But if you're going to take the brightest minds and teach them medicine, they're not going to put up with this narrow pathway in medicine forever. The curiosity is going to say, this is not enough for me, I'm going to go further. And hopefully that's what I learned in medical school, not to be hemmed in. It could have gone a different way, my life could have been easier, but it certainly couldn't have been better.
Lovely. I'm just circling back to earlier discussion. Your college professor who lit this fire about biology, a lot of that was your curiosity that just took you. And the approach to medical education at Yale that you experienced, which really relied on your innate curiosity. It wasn't telling you must do this and just be quiet and do what we say. You needed to use your own curiosity. This set you up really well for a life of curiosity and a life of meaning. And like you say, things could have gone differently in a lot of ways, but it couldn't have gone better for you. So I so appreciate this conversation. I'd like to give you a chance if you have anything else you'd like to add to our listeners, our viewers, before we finish.
We've spent some time together now, and it was my first interaction with you long term was during the pandemic. We were on a retreat and you were leading that group. And what you do is something that I have been wanting to do in medicine for so long. I did it very early in my career. I think it changed the trajectory of my career. I was running fast and about to burn out. And I ended up at Williams College at a conference, The Art and the Calling. I don't remember exactly what your retreat was called, but it was the same concept. It's let's get together as doctors and let's get into our own minds, mindfulness. Let's do these things. Let's not just survive. Let's do what we do best. And that was the first time that I spent a prolonged time with you. I repeated that at the Seversky mansion. You always take us to these beautiful places. I appreciate that, where we can contemplate. We go and what is new? I mean, isn't that what we all the doctors did from the beginning? We would go to places where we could contemplate and think things through. And as we get healthier and better, we can deliver something to the patient, because it's not easy and it's not nice a lot of times, the environments that we're working on. And but burnout is not necessary despite the institutional issues and all of that, because we are doctors. And that's why I like to think of us as doctors and not providers. We're doctors. We're something very special, and we were chosen. In my case, I was called. Many of us chose it because we had the capacity to do it. And so I think that medicine has been around so long, we're always going to be healers. We're always going to be teachers. And that's pretty much, and I want to thank you for giving us that opportunity and giving me those opportunities.
Well, I really appreciate your comments, and I thank you very much for this conversation. And I'm looking forward to our viewers and listeners to have an opportunity to watch this. So thanks again. Thanks for listening. We will include a summary of today's podcast with links about Donald Moore and other references that were discussed in the show notes. I'd like to conclude by sharing another practical contemplative exercise to help you flourish. It has to do with the curiosity that Donald and I spoke of. What might it be like to have curiosity for what you are experiencing right in this moment? So let's practice that. Let's just be quiet for a few moments now and just noticing what's here. What are you experiencing? And being, if you can, curious about that. Not seeing things that arise in your awareness as distractions, but what is it? What's this? What's this sound? What's this sensation in the body? What's this thought that comes into my mind? It's somewhat free-floating, but sitting quietly and just noticing what one's actual experience is a training of the mind to be curious that can help us directly apply that faculty of curiosity, we can call it a faculty, into many of our moments, many of our important moments with our patients, our clients, with staff, in the examining room, in the operating room, with family, friends, and loved ones. You can practice this very short curiosity practice anytime or from time to time to help build your skills with this amazing faculty we call curiosity. And by the way, in November, early November, if you're in the New York City area, EmPro will be hosting a conversation on curiosity that will include myself, Dr. Lisa Sanders, and Dr. Donald Moore. So if you're interested in that, please visit us at EmPro, www.myempro.com. If you'd like to know more about our peer support program at EmPro, please visit www.myempro.com/peer-support. If you're a physician or medical student and in need of urgent support, consider calling the physician support line at 1-888-409-0141. This support line provides a safe space to discuss immediate life stressors with volunteer psychiatrist colleagues who are uniquely trained in mental wellness and also have similar shared experiences of our profession in medicine. For information about me and my work, in addition to EmPro, you can visit www.mickkrasnermd.com or www.mindfulpracticeinmedicine.com. And I hope you'll join us for future episodes.